A warm welcome to all of you to this first webinar of 2021 of the Swiss Implementation Science Network. We are absolutely delighted that we have a large group of colleagues from Switzerland, but also from Europe and even from other continents who join for this session. And I have the huge pleasure today to introduce to you an implementation scientist from the United States, Dr. Smith. Dr. Smith is an associate professor in the Department of Population Health Sciences at the University of Utah School of Medicine. And he is also the co-director of the Health Behavioral Intervention, Implantation and Translation Core of the Diabetes and Metabolism Research Center in that at the University of Utah. Before he was at Northwestern University in Chicago. And Dr. Smith, his background is health psychology, but he has over the years also gained a lot of expertise in implantation science and has a number of research projects that are being funded by the major funding agencies of the United States. Dr. Smith is associate editor for the journals Preventive Science and Families, Systems and Health, and has published in 2020 a seminal paper in implantation science on the implantation research logic model. And we were absolutely delighted that Dr. Smith embraced the opportunity to join us at relatively short notice, and from the United States is now being part of our Swiss Implantation Science Network. For those of you who have not yet been part of the Swiss Implantation Science Network educational offerings, I would like to inform you that during the lecture of Dr. Smith, that also will have some interactive opportunities, that there is an option in the chat to note down your questions, and we will take up these questions during the discussion after his lecture. So also we will now first give the word to Dr. Smith, and I would like to ask AVL to let Dr. Smith show his slides.
Thank you so much for that great introduction, and I'm very excited to share this work with everyone. Let me go ahead and get the slideshow going here. Great, so I hope you're seeing the actual presentation and not my notes. And do let me know if there's any issues with the audio. I can move closer or even switch to a Bluetooth device if it's better. So as mentioned, I'm going to talk today about the Implementation Research Logic Model, or the IRLM, which is a method for executing, reporting, and synthesizing implementation research projects that was published in Implementation Science in September or October of this past year. So as you all know, implementation science is definitely a team science, and I have a lot of folks to acknowledge who were part of the development of the IRLM, both kind of in the early stages, but also in the refinement, as well as have been using it over the last 6 to 8 months since the publication came out. I especially want to note the for prevention implementation methodology at Northwestern that I used to be associate director for. This was my kind of professional home for the last 5.5 years, and they were very instrumental in the IRLM coming to fruition. So I want to start out actually with a question. I assume everyone here has a little bit of knowledge about implementation research, even if they're not doing it themselves already. And I want to just ask the question in a poll here, what aspect of implementation research have you found to be the most challenging? And the options are demonstrating how you are integrating determinants with strategies and the outcomes, justifying the implementation strategies that you plan to use or study, planning for an implementation study with diverse stakeholders and multidisciplinary researchers, or reporting comprehensively what happened in an implementation. Now, these might be challenging in all of them. There isn't in all of the above. I want to see which one people think is the most challenging. So we'll give a few minutes to answer the poll question. I think we have about 50 of our 86. All right, great. And I will not be answering, so maybe that's one less person we need to wait for. Our vote's still coming in. We're at 80%. Okay, looks like we're kind of settling in on the finding. We've reached saturation or some other statistical word here. All right, so let's we have 83%, and as I mentioned, it seems like it's kind of settling in on the first and the third response. So about a third of you all are saying that demonstrating how you are integrating your determinants with strategies and outcomes is most challenging. Other third have indicated that it's planning for the implementation with diverse stakeholders and multidisciplinary researchers. So this is a bit of a trick question. In that the implementation research logic model is intended to help with all of these, but it is also really interesting to think about what challenges people are really kind of saying are they're looking for a solution to. So I'll talk a little bit as much as I can about these two for both the planning as well as the kind of integration aspect. So the first question that we always kind of get asked, or people think about when you're talking about a new model, is, do we actually really even need a new model? So we have made the case that an implementation research specific logic model is needed for a number of different reasons. And the first one actually is one of these challenges that you all showed, is that integrating the necessary conceptual elements of implementation research, which often involves multiple models, frameworks, and theories, is really challenging. And this is, I don't think this is something that just new folks in the field, kind of struggle with. Those of us who have written many projects and grants and have been involved in lots of these, I think we still struggle with which are the best ones to choose. When we have our kind of determinants framework and our outcomes and our strategies, how do we actually fit those all together and make them into a coherent picture? Two that we know has been kind of a challenge in implementation research, and this is actually in all research, but I think implementation research presents sort of a unique challenge to this, is that there is a push towards conducting research that has greater transparency, that is more rigorous, that is open, basically meaning that you are very transparent and clear about exactly what you did, and you provide those materials to folks. The field has struggled a bit with specification, particularly around implementation strategies. And then our field is relatively new. And so the challenge of reproducibility is only now kind of coming into focus. But this is going to be something that the field will struggle with and need to rectify as we move forward and become more mature. So when we talk about kind of these major aspects, so rigor is the strict application of scientific method to ensure robust and unbiased experimental design, methodology, analysis, and interpretation of the results. And rigor really comes from obviously having a very well thought out and well specified research design, but also each of the different components of methodology, analysis, et cetera, is going to have to follow suit with that original kind of overarching design or approach to the study. We did argue in the paper too that we need to improve the specification of the phenomenon in implementation research, because this is really going to allow us to understand how strategies work, for whom and under what determinant conditions, and which actual implementation outcomes can we expect to be immediately affected by different strategies, And then, of course, we are always interested kind of in those downstream clinical outcomes whenever we're doing an implementation study. So the other thing that logic models help us to do is they help us to explain or put forth a testable way of explaining the phenomenon through the specification of the relationships among multiple levels of variables and other factors that can influence the findings. And what we're really trying to do is to enable prediction of outcomes, not just the testing of a hypothesis. We want to get to a place where we can actually say, if you do this, this is what is likely to happen. And the field is really not at that place yet in most areas. There may be a few kind of minor exceptions to that. But for the most part, that is not a general place that we've achieved yet, is prediction of outcomes. So, we I think successfully argued that we do need another model. But I want to remind everyone of a quote by George E.P. Box, which I think is very helpful. He said that essentially all models are wrong, but some are useful. So, kind of keeping that in mind, that this is intended to have utility. It's not necessarily intended to be the end all be all, to fit every single need, or to necessarily be exactly perfect. It is going to be a heuristic. It's going to present something that is general, that needs greater specification. But we're hoping still that folks find it useful for various reasons. I want to kind of just go back and talk about how we developed the implementation research logic model, and then talk a little bit about the elements that comprise it, as well as some of the intended uses of the IRLM for implementation researchers. So this really began with a series of case applications. That was really kind of our initial process of generating what the model might look like, what elements needed to be included, and giving a little bit of a test case about whether or not it actually was helpful in any way, shape, or form. So we started this in the study of implementing a new model of patient care that was also, that required a new physical hospital space, and all the implementation strategies that went into translating this model of care across a huge rehabilitation hospital. We also used it in the first 6 months of already funded implementation research projects that we used it really for planning and describing the implementation research of the trials. But again, this was not like, totally prospective because these were projects that had already been reviewed. We had already put forth a proposal and they had been funded. So at this stage, we were really looking for kind of the missing pieces, whether or not we actually had proposed all of the strategies that were necessary, and also looked at places where we needed to potentially add measurements so that we could explain some of the phenomena that we might see within the trial. We also applied this in the later stages of a nearly completed implementation research project that really was about summarizing and reporting what we had done, more so than helping us plan or to look for gaps or issues that we had not considered. It was really more of an issue that we've learned. Here's all the things that we've done. Let's put it into the IRLM and see if it makes sense to folks and is a useful way of presenting that material. And then we do have post-training results that I'll present here about the usability and acceptability of the IRLM. And this was done in a 2-day training that was hosted by a thing called ISCI, which is the Implementation Science Consultation, Coordination, and Collaboration Initiative, which essentially is a coordinating center that's funded by the National Institute of Allergy and Infectious Disease under the Ending the HIV Epidemic. And what this initially started out with was we oversaw 65 planning program grants or planning project grants in the first year. And then there were about 40 grants that were funded in year 2, which were coming up on the end of now. So this was used in a 2-day training for those first 65. So we got a lot of information about how to use it, what it was good for, and I'll kind of share those as we go through this presentation. So really important to understand the structure of the implementation research logic model, and we decided to begin with the common pipeline logic model format. There are multiple logic model formats. I think most of us are in at least medical sciences, healthcare, and social and behavioral sciences are probably most familiar with pipeline logic models. And this is kind of what they look like in, kind of broad strokes. You initially start with the resources and inputs. You describe the activities that will be done, the outputs that occur from those activities, the outcomes that are achieved, and then the impact of the overall program. This is a great logic model format for program evaluation. As you can probably see, if you have any idea what implementation research is, it doesn't fit very well. We don't talk about these things in the same way in implementation research. It's not that you can't retrofit or you can't kind of, contort an implementation research project into the traditional pipeline logic model. But when you do so, it's not very helpful. And I've done this myself for multiple grants that required a logic model. We've done it, for the CDC or the USDA, our funders that I have some grant funding from that required this. It was not a useful exercise at all. And actually looking back, they're kind of nonsensical, to be totally honest. So what we thought is we would actually try to, use the format itself because it's familiar to funders, it's familiar to investigators, to readers, and to grant and article reviewers. But we needed to replace the components with things that were more germane to implementation science. So the idea was to really integrate existing frameworks, those that people would also be familiar with, as the core elements. The other thing that was a little bit more, I think, moving towards a potential kind of scientific contribution of the IRLM is that rather than having just these different buckets of kind of things that you have to kind of place appropriately in the pipeline, we wanted to have a pipeline that was actually a testable causal model. And I'll kind of explain that as we go through what we call the generalized theory of implementation research. So here's the theory and elements of the implementation research logic model. And this goes into, again, the generalized theory. So this, again, is a general theory of how we think implementation research projects actually work and how they should be sort of conceptualized to some extent. So we essentially said that implementation strategies are selected for a given evidence-based program or intervention, and that these are the strategies you choose are related to the implementation determinants. So you should choose implementation strategies that are context specific to the barriers and facilitators that you're attempting to leverage and or overcome within your service delivery system. The second kind of premise of the generalized theory is that strategies work through specific mechanisms of action to change either the context or the behaviors of the implementers within the context to lead to the implementation outcomes. The implementation outcomes are the proximal impacts of the strategy and its mechanisms, which then relate to the clinical outcomes of the evidence-based intervention. So this is a really kind of core and critical piece of any implementation research project, is that we have to establish that you've actually moved the implementation outcomes, not just had a clinical outcome, because of course that's part of the paradigm of implementation science. So the IRLM in this particular way, at least as it relates to the generalized theory, is to help aid in the specification of the relationship between the foundational elements of an implementation research study. So the 4 foundational elements are part of the 3 points above, but essentially what we would say from a causal mechanism perspective is that our determinants inform which implementation strategies we choose, which act on mechanisms of action that leads to our outcomes. So that's the format of the pipeline model. The definitions very briefly, because I know most folks are going to have some familiarity with these. So our determinants are the factors that prevent or enable improvements. We often call these barriers and facilitators. People also call them effect modifiers, or often test them as a moderating variable. You can also test determinants as mediators, but maybe less commonly. These also are indicators of links in a chain of causal mechanisms, which was what Laura Damschroeder had talked about when they put forth the CEFR model, which is the Consolidated Framework for Implementation Research. Implementation strategies are the things like the supports, the changes to, and the interventions on the system that help to increase the adoption of EBPs into usual care. So these are the things targeting implementers, targeting the system of care, not the intervention itself. That's the clinical intervention. And I'll try to be clear about using terminology of implementation strategy when I'm talking about system level interventions, and clinical interventions when I'm talking about the patient level interventions that we're trying to implement, or practices that we're trying to implement. Mechanisms of action are processes or events through which an implementation strategy operates to affect the desired implementation outcomes, and that was defined by Carol Lewis and colleagues. And again, I've already kind of mentioned that we have kind of 2 levels of outcomes. We have implementation outcomes, which we view as the effects of deliberate and purposive actions to implement new treatments, practices, and services, versus clinical outcomes, which are the direct effects on participants or patients of the EBP. And those are typically measured in terms of like symptoms, diagnostics, as well as like infections averted, things like that. There's a number of different implementation research logic model formats that I'll show here, and this really kind of gets us into the pipeline approach. The formats are intended to kind of fit different, kind of circumstances that you might find yourself in when doing implementation research, and also to potentially start to portray the actual research design. So of course, there's an experimental design that always goes with every project that helps you actually test your hypothesis. And you can use the IRLM to start to show some of those core elements. So here is the what we kind of call the like basic implementation research logic model. We have our determinants box. I'm using the consolidated framework for implementation research here, mostly out of familiarity to a lot of folks, but the theoretical domains framework, PRISM, other implementation research frameworks that have determinants specified could easily be plugged in. And I want to be really clear, this is a framework. It is not intended to be something that is completely rule governed. So you do not have to use CEFR, but you do have to use some determinant framework. We then have our implementation strategies, and these can obviously vary quite a lot depending on your situation. We have the mechanisms through which the strategies work, and we have our outcomes. Now, let me see if I actually have this here. Yeah, okay, so usually I have a little slide where I overlay like the CEFR model, the Byron Powell, Eric compilation into the implementation strategies. And then in the outcomes box, some of you might notice that this is actually a Nola Proctor and colleagues 11 paper on implementation outcomes, just turned on its side. So again, I did not create any of these things from scratch. These are all borrowing from other well-established models and frameworks that folks are familiar with. So let's get into some actual kind of different formats. So we also have an implementation research logic model for what we call comparative implementation trial. Comparative implementation is where you have two bona fide implementation strategies that you're comparing against each other, very analogous to comparative effectiveness, which is why we called it comparative implementation. In this particular thing, you may specify that you have two different strategy conditions. And within the IRLM, you could say, here are the different discrete strategies that differentiate the two experimental arms of a comparative implementation trial. But again, that's kind of the core element of that kind of trial design. And this is how the implementation research logic model could be used to kind of delineate that. We also have a number of situations where we have done implementation projects in multiple contexts. So in primary care and then through pharmacies or through a community-based organization and a healthcare organization. As you can imagine, you cannot have just the contextual factors and determinants for one of those contexts. They really have to have both. So we have just an example here of being able to provide the unique determinants for each of the different contexts, and then potentially the different implementation strategies that are used in each of those contexts to implement an overall evidence-based program. We also have a number of situations where we are trying to optimize implementation. So these could be kind of adaptive implementation designs, things like MOST trials or SMART trials get into this kind of thing, factorial. There's also a new trial design that I co-developed with Hendrix Brown called the Rollout Implementation Optimization Design, or ROIO design. And so the IRLM can be used for those kinds of designs as well, where you're testing kind of the iterative improvement of multiple strategy packages, or again, like in the case of a factorial, kind of multiple components and their potential interactions with each other. So the logic used to actually say, here's our different conditions that we'll test for optimization. We also have, and I think this is something that people have asked for over time, and this is becoming the most commonly used format of the implementation research log, is one that actually includes the clinical intervention. So as you can see, the thing that's different here is that there is an arrow that shows the connection between the determinants and the clinical intervention, but also that the intervention dictates, the intervention and the determinants dictate which implementation strategy you should be using. The other thing that's important here too is that this recognizes the indirect pathway to achieving population level clinical outcomes, but there's also a direct pathway between the intervention and the clinical patient outcomes that is in implementation research a little less of an emphasis. One of the reasons that this is becoming more important is that a lot of clinical interventions are multi-component, they are complex behavioral interventions, And so it really helps a reader to actually see the components and the elements of the clinical intervention being specified to really get the full conceptual picture of why certain strategies were selected. We've also seen the case with a lot of these planning grants and kind of early stage small trials where the clinical intervention is not predetermined. So when working with some potential adopting sites and clinical partners, you may actually go in, do a needs assessment, evaluate the within the context that you'll be working in, specify what you're hoping to achieve in terms of your implementation and clinical outcomes, and then actually go to literature and look for what clinical interventions could be used. And so actually having the rest of the model, basically this, then allowing you to actually choose a clinical intervention that is actually going to fit the context and the rest of the project. We also had a situation where we had a difficult time differentiating the mechanisms of action that were specific to the implementation strategies versus those that were part of the intervention. So we created another logic model version that has the intervention mechanisms and the implementation strategy mechanisms, so that those could be clearly differentiated as well for readers. And this was part of a grant proposal that was funded. So it must have been useful to some extent. So those are a number of different formats. This is definitely not the whole universe. I have a number of others in the back of my head that could be presented, but this is just to give a sense of what is available and also to encourage people to be creative. So you don't have to use one of the pre-existing formats that we've put forward in the article. You're certainly welcome to adapt and to tailor the logic model in a way that fits your particular project. I'm going to check the chat really quick if I can figure out how to do that and see if there's any questions. Okay, thank you. Okay, so we are moving forward. So using the IRLM for different purposes and stages of research. So I've sort of already, I guess, alluded a little bit to using this at different stages, but let's talk about those a little bit more specifically. So in the planning stages of an implementation research project, we often begin with the known parameters of the study. So it really depends on when you're jumping into using the logic model in planning, if it really is kind of one of the things that you'll use from the very, very beginning, versus something that maybe you're using to organize your thoughts after you've already done some exploration and planning. It could be a little bit different than this, but for the most part, what we notice in the planning stage is that you often begin with known parameters. Our suggestion is to work from the bookends of the implementation research logic model, which is the context and the outcomes, because these are the things that are most commonly known when going into an implementation research project. So the really kind of understanding the implementation context, being able to put forth the primary barriers and facilitators that are present, but also working with your community partners or working from an RFA or something along those lines, you can just specify what you're trying to achieve and then kind of work backwards to fill in the implementation strategies that will be required to achieve that, the mechanisms through which those strategies are likely to work if you're going to achieve the outcomes. And then again, as I mentioned already before, you can also select the evidence-based practice act if it wasn't already something that was known right from the beginning. If it's known, it obviously makes your life a little bit easier to be able to complete the logic model with your community partners. So we do recommend, of course, that you do work with your community partners and the organizational stakeholders to fill in the implementation strategies in particular. But of course, if you're not doing like a full comprehensive evaluation of the clinical or delivery context, this is a place where you could use your community partners. And there's various methods for actually collecting this, whether it's focus groups, Delphi methods, key stakeholder interviews, all those kind of things that you could use to actually populate the context and the implementation determinants. The one place we found the most important, though, are the proposed implementation strategies to talk with community partners about. And there's two reasons for that. One of which is every organization is already using some implementation strategies. So we're going to essentially kind of leverage the ones that they currently use, but we're also going to oftentimes introduce something new. And whenever we're trying to propose a new implementation strategy, we want to make sure that that is actually something and something that is acceptable to our community partners. So actually getting that input and having their perspective and kind of co-creating the logic model and the proposed strategies is likely to serve well in the long run. The other stage that we talk about is executing. So executing is really kind of using the implementation research logic model as a protocol, or almost as like an implementation blueprint for an actual project. And it can also form the basis for ongoing tracking of what actually occurs during the project, what is altered, so what modifications have happened from a totally prospective plan, and also protocol deviations. So I make a differentiation between kind of modification and altering versus deviation. So modification and altering is pretty standard within implementation studies. We know that we probably have an exact perfect thing. It's also not like fit. And we know that healthcare systems and delivery systems change over time. So we may have to adapt to a changing context. That is in contrast to significant protocol deviations. So let's say you have 5 sites. They're all supposed to be doing the same implementation strategies, but you find out that one site actually just did not do one of the strategies at all. That would be a protocol deviation, not an adaptation in most situations. So we try to differentiate those two things. Once you've actually an implementation project, you can use the IRLM as a way to report what actually happened during the study. So what did you actually find? You can also report the hypothesized relationships that were observed, or actually show the empirical relationships between the elements if they were actually tested in that way. We have found that it's really helpful in communicating the findings of studies because they can be often quite complex. We're often looking at multiple strategies and obviously multiple outcomes. And so actually showing the conceptual relationships between those and what we think actually led to those difference of findings can be really helpful in a pictorial format rather than purely through written text. The one thing that we haven't done as much of, but trying to be a little bit forward thinking, is to use the implementation research logic model as a way to do this across the conclusions or findings of multiple implementation projects that are evaluating either a similar evidence-based program or evidence-based programs in a particular context. So what the intention here is really to talk about what is a generalizable guide if you were to, let's say, try to do integrated behavioral health within pediatric primary care. Maybe not necessarily that dependent upon the evidence-based program. It's more about the context, the implementation strategies that you can then tailor and adapt based on your particular setting and the particular intervention that you're implementing. But we really would like to kind of move up to providing generalizable guides, as well as parameters around what could be kind of taken out or what can be added and still likely to be effective. So again, this is a bit more forward thinking that it is something that is happening currently. There are multiple efforts that are happening to do this in the future. So we're collecting data in a way that will allow this, but it's currently kind of still on the horizon. Okay, no questions yet. Okay. So one of the challenges, obviously, is actually populating the implementation research logic model and then, of course, making good use of it. The thing that I really don't want to see or have people feel like that this is just an exercise that they go through and then they put it on the shelf, use it any further. And I say that because this was a required element for a number of different RFAs recently. And so just kind of trying to get ahead of people just feeling like this is something that they're required to do by the funder, but isn't really useful for them. So the one thing I want to point out here as we move forward is that I already mentioned that the logic model is not rule governed. It is has a number of guiding principles for how to make the best use of it. It is not something that has to be, there's not like a set of things that you absolutely have to do and you can't stray from. We want the logic model to be flexible. So we did guiding principles. So principle number 1, and this is coming out of kind of the need for for better specification and better kind of openness about what the context and everything that goes into an implementation project is is we say strive for comprehensiveness. Again, aspirational, strive for, not you have to be. So in terms of actually being comprehensive in the elements of the logic model, we want folks to include all relevant determinants and not simply report those that are hypothesized to be related to the strategies and outcomes. You're going to see this is really similar to our strategies recommendation as well. But what happens here is that I think we tend to kind of limit our own thinking about what influences our outcomes. And so we say, I picked, this strategy to address this one barrier. Well, we know that strategies and barriers do not have a one-to-one relationship. And so there may actually be multiple complex relationships, at least put in the logic model, not necessarily tested. But we want to make sure that all of those relevant determinants are listed so that they can be taken into consideration when interpreting the results. The other thing is that you should note the valence. And I'll give some examples of what we've done. So we've done things like adding plus or minus signs to indicate facilitators or barriers, and a plus/minus for when it is highly variable and we can't say that across like multiple settings that we're engaging that it's always a determinant or always a barrier or always a facilitator. So just an indication of here's the directionality of this particular factor or determinant. There's also a really cool coding system Schroeder created to indicate the relative strength of the determinant. So it's a multivalent rating system that goes from -2, meaning it will be a significant negative barrier or have a negative impact on our implementation, versus a +2, which is sort of seen as a significant facilitator of implementation. One thing that we wanted to do to help others understand your logic model is we suggest not using study-specific adjectives or changing the names of determinants from that you're using. So some examples of things not to do would be saying like it's greater relative priority, because greater, that doesn't indicate a whole lot. It's really a subjective, kind of an adjective. So something like addresses patient needs, also not very useful, or saying that there's a good climate for implementation. What does good mean? So trying to use the actual name of the determinant and one of these rating systems. So going further, when we look at the implementation strategies element, we want you to list all strategies in the system. And this is really getting away from kind of early implementation research. And unfortunately, it still happens, is that people only talk about the strategies that they're introducing, which is sort of almost a willful ignorance of everything else that's happening within the system that has an impact. We can't just think that because we're not introducing this cool new thing that's conceptually related to our intervention, that it's the only thing that's going to have an impact on what happens. So you want to list all the other strategies that are also currently in the system as well that could benefit or impede your implementation. So second, strategies should be labeled if possible, especially in the reporting of an implementation study, to indicate whether they were in place in the system prior to the study. They were initiated prospectively for the purpose of the study. And this is really true for experimental study designs, where we do have to indicate which strategies are going to be serving as our independent variable. And then also there is the case that we are likely to remove or to prune some discrete strategies as a result of them being ineffective or being too onerous. So just being infeasible. We also know that it's likely that you're going to introduce other implementation strategies during the course of a study to address an emergent barrier, or you find that you need to supplement other strategies because of low initial impact or other factors. So you can kind of see where I'm going here with kind of this comprehensiveness piece and being very specific about what happened in the course of the study. This is relevant for the IRL during the planning phase, but also as part of an ongoing tracking system. We do have an article in process about, it's called the Longitudinal Implementation Strategy Tracking System, or LIST, because you have to have a cool acronym or no one's going to remember it, that helps us actually track implementation strategies and their modifications over time that can then be plugged into the strategies box of the IRLM. So lastly, this is really straightforward. In the outcomes box, list all your measured outcomes. If you're going to evaluate it, if it's going to be part of anything, it needs to be listed. It can't just be your one primary outcome, or maybe the kind of top 2 outcomes that you're looking at changing. Because we know that there's a nested structure or kind of a hierarchical structure in implementation research between the logic or between the implementation outcomes. So if you have a failure of adoption, you're not going to get to reach. If you have a failure of fidelity, you're not going to get to high level of outcome. So you have to kind of show all of those to make sure there's not a gap or a break in that causal mechanism. So our principle number 2 is to somehow indicate the key conceptual relationship. So in some ways, you're already doing this by placing the different factors in the right box of the implementation research logic model, but there's a better way. There are ways to get better specificity there. So you want to indicate the relationships between the elements in a manner that aligns with a specific theory of change for the study. So this could be like individual behavior change theory if you're trying to change the behavior of implementers. This could be organizational change theory if you're trying to really change the culture, the climate, the workflows, kind of at a higher level of the organization. But either way, using some kind of notation to indicate the conceptual relationships. We have found that superscripts tend to work the best, using 1s and 2s, A's and B's, etc. Getting creative with using bolding versus unbolded, and I'll show an example of that and how that can be indicative of different things. We have used color coding and arrows, but we want to kind of have these be limited, in part because I kind of mentioned already that there is often not a clear one-to-one linear relationship. It's often multivariate, and those are really hard to show via arrows or color coding. Color coding and arrows, as you can see on the last point, are really useful when showing the IRLM in PowerPoint. Because they can help you actually, emphasize and de-emphasize certain aspects, but it's really hard in a static IRLM that you would present in like a grant or a manuscript. These notations facilitate reference in text as well, so that you can actually say we hypothesize this causal relationship as evidenced by path A in the IRLM, for example. And it can be something that really facilitates your data analysis plan, but also the specification of specific study hypotheses as well. The principle 3 is to specify the critical study design elements. Now, this is not always possible depending on what kind of design you actually are using. So if you're using a non-experimental design, this may be less applicable, but for most of us, we have some kind of experimental design, so it's going to be relevant. So we want to always indicate the primary outcomes in some particular way at each relevant level of the study design. So if you're trying to change clinician behavior, clinic behavior, organization behavior, et cetera, you'd want to indicate the primary outcome that shows that you've done that for each level. And of course, the levels should align with the specific aims of the study, as well as the levels targeted by the implementation strategies. So let's see. Yeah, so our main kind of suggestion is to include downstream health services and clinical outcomes, even if they're not measured as well, as of course they're important for understanding the logic of a study and the ultimate health-related targets. So again, kind of more specificity here. If you have a quasi or experimental design, you want to clearly label any independent variables. This is predominantly going to be these that you introduce or manipulate, or you differentiate study conditions in a kind of comparative implementation study. So specifically for comparative implementation trials, you want to indicate the determinants, strategies, mechanisms, and potentially the outcomes that might differentiate between the conditions. You might need to use an IRLM for each arm of the study, depending on its complexity and how different they are from each other. And we have seen this in a couple of different projects already where it didn't make sense to have it in one because they really had so many different unique characteristics that it was difficult to do that in one IRLM. For optimization designs, where the intent is to try to specify different combinations or determine which of the different strategies is best, you want to actually use the IRLM, as I had already shown before, to specify the different combinations or conditions that are being tested. So some additional specifications. There are any number of additional elements that you might want to notate or indicate about the design of your study. So you might want to notate the things that have been or will be measured versus those that are based on researchers' prior studies or have been inferred from findings reported in the literature. You can indicate when implementation strategies differ by level or unit within the study. So like in large multi-site studies, strategies might not be uniform across all units, and that might be by design. And so you might want to indicate those in some way. As I've mentioned multiple times, be creative. There really is no wrong way to use the logic model if you're following the principles. So certainly, if there's other ways of doing things that can be helpful in getting readers to understand your project and helping you and your collaborators and community partners carry out the project, certainly feel free to make it your own. So I want to take us through a completed hypothetical implementation research logic model. This is based on a couple of projects that I have been involved in that we have used the logic model. So it's not completely hypothetical, but it's an amalgamation of a couple of other studies. So this is an obesity management intervention that is implemented in community health centers, which are essentially just primary care practices in the community. So in this particular situation, we started with an intervention that was known. So we wanted to implement a behavioral obesity management program. And it's not totally that important to see all the components of it, but this is the components of a behavioral obesity management program. We also knew what outcomes we wanted to achieve at each level, and you can start to see the level of specificity that we're getting into here. So we have our traditional like re-aim or proctor outcomes here with reach, adoption, implementation, acceptability, feasibility, maintenance, and cost. So we have pretty much everything notated, even with greater specificity about what exactly are we looking at what level. We have our clinical and patient outcomes as well that we were able to show, and this is actually a hybrid effectiveness implementation design. So we will be looking at the clinical impact as well as the implementation outcomes. We also knew the community health centers that we were going to be working in. So we were able to actually populate our determinants. We were able to indicate our valences for which would be the kind of primary facilitators, but also the major barriers that we would need to select strategies to overcome. And then because this was a scaling up kind of a study, we know what some implementation strategies that have been used in prior work, but also proposed to use some new ones as we went into the community health centers. Mostly a learning collaborative was kind of the biggest one, but there are some other things as well. And then we hypothesized a number of different mechanisms for the effects of each of our strategies. So one thing that we did here, again, I mentioned already that we did valence coding to indicate which way each of these different determinants was going to fall. You can notice here too, if you're familiar with CEFR, we basically use the exact wording of the CEFR framework. And so we have intervention source, the relative advantage, and we were able to use the notation to show that this is a barrier or facilitator rather than including an adjective of some sort. The next thing we did in terms of actually doing the superscripts and creating the conceptual connections, and I would suggest this is something that is pretty uniform. The best way to do it is to start your labeling with the implementation strategies. So in our case, we have A through L, however many that is, 10 different unique strategies. So once we actually labeled those, we could then go backwards in time, or backwards in the logic model to basically say, we think that the training modules and the learning collaborative mostly address the barriers around acceptability and complexity of this particular intervention. Now, that's not the only things that are done. You can see down here under characteristics of individuals, these strategies also address the knowledge and beliefs about the intervention from the interventionists, also their self-efficacy, and of course, the training that's needed to actually get up to speed, which these are highly trained individuals. So we saw previous training actually as a facilitator rather than a barrier. And then also the engagement of champions who also need to be trained, and they will be leading the learning collaborative. So you can start to see like there's multiple kind of determinants that are addressed by each strategy. And similarly, moving forward, the primary outcomes we think are going to be the result of the training strategy are improving reach, improving adoption, acceptability, and feasibility, and maintenance sustainability. But we think they're working through slightly different mechanisms to achieve that. And so there's ways to actually convert all the different paths into tables as well that can make them a little bit easier to kind of read or differentiate from each other. But most of this is really about kind of getting the team on board and getting us to specify all the things that are going on in this particular study. So here's and then the other thing we did here too is we bolded our primary outcomes. We also did a couple of other things I think that are kind of unique in that we bolded the primary pathway, and then we have in parentheses and not bolded, we have secondary pathways. So these are things that we don't think are going to be the most related to this path, but also could play an impact. So we're acknowledging that there are other factors that might need to be considered as covariates or some other kind of thing. Here's another implementation research logic model. This is one that was recently submitted in a grant that I am PI of. And this is a IRLM for implementation of clinical practice guidelines for pediatric hypertension and blood pressure management. What we did in this particular trial, which was a little bit unique, is this is actually the IRLM to summarize a year and a half's worth of work of actually engaging with our community stakeholders to co-create and identify a multi-tiered implementation strategy package. So this is where we actually did use color to differentiate, green being our tier 1 strategies. These are the strategies that we think in combination will address all of the primary barriers that we have specified here and achieve our major outcomes. The thing that's unique about this study design is that we are going to be doing an optimization design. So we're going to start with our tier 1 strategies as a package, evaluate their effectiveness, modify the strategy package, which is likely to include the addition of strategies from tier 2. We will test again in another cohort of clinics, and then we will again evaluate and optimize, and we could start to pull from the tier 3 implementation strategies. So the tiering system here was really kind of which ones are the most feasible, most likely to be effective, and our highest priority with our community stakeholder group. And so this is just a way for us to show the different tiers, but also the conceptual connection so that a reader says, okay, you have this huge list of strategies, you pick these as your top tier, how do we know they're going to be effective? And we were able to demonstrate that they have sufficient coverage of all the barriers that we think it's a package that could actually be effective without additional strategies, but our design is intended to try to figure out what that is. So I have a question that I'm going to have you guys put in the chat because it's kind of a free response. So this question is really like, what aspect of the IRLM, now that you have some kind of some knowledge about what it is, what aspect do you anticipate being the most challenging if you were to use it for an upcoming or an ongoing implementation research project? And I gave some examples of things like specifying the relationships, being comprehensive, getting your stakeholders and partners to actually understand it, figuring out what are the strategies and what are the interventions that you might use, thinking about the potential burden of the time required to complete it, or anything else under the sun. What do you kind of anticipate being the most challenging thing? Mechanisms has come up, okay. Sure. Specifying relationships, identifying mechanisms, yep. Time required, yep. Defining outcomes, being comprehensive. Lots of different aspects are going to be challenging, okay. What I would expect. Oh, being comprehensive without pre-concept, okay. Yep. Having it not just sit on the shelf, so having it not be something that just gets done once as an activity and then. All right. Okay, so get back to some of these things that you guys have found challenging. I think in the chat, as we get into our discussion here in a few minutes, I think I would love to hear some people's perspective on why they would think or what kind of challenges they expect with these different aspects that you reported in the chat. I will get to mechanisms too in a second. I know I've kind of like half ignored that, and I'll tell you why in a minute. Okay, so I do want to acknowledge that the IRLM cannot do everything for everyone, and it doesn't do all things. So we totally 100% recognize and also suggest that you need supporting text and resources for readers and for yourself to probably make full use of the IRLM. So having data around determinants, the data that you actually collect or where you've actually gotten that, those ratings, you can use text, tables, and figures to do that. Actually specifying your measures. Of course, there's no place in the implementation research logic model to actually specify the name of the measure, give it psychometric properties, the timing, who gets it, all those things would obviously have to be in text or table as well. The other thing that we know that needs to be done is strategy specification. So there is potentially, depending on the number of strategies, you could start to operationalize and define exactly what you're doing within the IRLM, but likely it's going to become too text heavy. And so you'll need a table or a figure to do that. The actual paths that are supported by theory, that would have to be something that would be included in supplemental material. The actual design of the trial and the methods or approach for carrying that out, we can give some indication within the IRLM of what kind of overall design you might have, like comparative implementation, optimization, et cetera. But you'll need to have something that explains that in more detail. And then, of course, if you're using an implementation process model, something like EPIS, or getting to outcomes, you would want to have an explanation of how that's going to be applied specifically to your project. And as I mentioned earlier, if you use scripts or other notations, it becomes really easy to actually refer to the IRLM within these other documents and other places within a project. So it's almost serves the purpose of being like a figure that you would refer to, with other pieces. But really briefly, I want to talk about the acceptability and usability of the IRLM. I already mentioned this was part of an EHE planning project grantee training survey. And so we conducted this summit that was 2 days long, very intensive. It was done by the Coordinating and Technical Assistance Center, which was us. That's called ISTE. And what we ended up having was 132 participants, representing 63 of the 65 funding projects. 129 of those completed the pre-training survey. 66 completed the post-training survey that was done 6 weeks after the training. And you can see a little bit of the breakdown here as well. So 45% indicated having fully completed the implementation research logic model for their project, which was essentially homework. After the summit itself, we used the implementation research logic model as the primary teaching device over this entire 2 days, and then asked them to go home and work with their implementation partners to fully complete it. So we asked then in the survey 10 items related to the IRLM specifically, and then one about the general logic of implementation research, and it was rated on a 1 to 4 scale. So what we found is that the IRLM was rated either moderately or very helpful. That was the 2 highest categories in the following places. So people said improving the rigor and reproducibility, serving as a roadmap for our project, clearly reporting and specifying the project plan, and understanding the connections between the different elements. And you can see the percent, so it's 2/3 or better for all of these. The other items also were pretty positive, but not quite as high. So identifying gaps in the logic of the project was also rated fairly highly. And then you can see kind of the bottom half, which is still really good. It's 50% or better. Talked about deepening your knowledge of implementation research methods, planning the project, developing consensus and understanding among the stakeholders, and identifying gaps in their research questions and analyses. Some additional results that are probably worth showing is that nearly 3/4 said that the worksheets that we provided during the summit were moderately or very helpful in completing the IRLM, and I'm going to show this here in a second. And again, 3/4 said that their knowledge of the logic of implementation research increased moderately or very much after the 2-day training, and this did not vary as a function of their previous training or experience with implementation research. So there's a few resources for using the IRLM that I think people will find helpful. These include a quick reference guide, some worksheets, obviously the templates that I've shown today, as well as some examples, and there is a website that is kind of continuously being updated. So here's an example of the quick reference guide. This really just kind of gives you like what kinds of elements you should be considering to add in here. So it's kind of something that has side by side with your blank ones. You're like, oh yeah, that's what I'm supposed to be putting in this box of the logic model. It goes through some definitions. And then also, again, like here, it lists all the potential different kinds of implementation outcomes that you might consider to add with that particular box. We also have these lengthy worksheets that go into much more detail about each of those different elements. So we have a determinants worksheet, we have an implementation worksheet, and we have one for strategies. Yes, the mechanisms one is glaringly obviously missing. I'll talk about mechanisms in a minute. I keep kicking it down the road, but I think it's, yeah, you'll see why. So here's the link to the Implementation Research Logic Model website by the Center for Prevention Implementation Methodology. And it has all of the templates, it has the worksheets, it has the quick reference guide, it has all that material, as well as some example completed IRLMs available for folks to take a look at. It also has another presentation that I did about the IRLM, which is basically exactly what I just said here, so probably not useful for you all, but for other collaborators, you might want to point them to this website for additional training and information. That is my thank you. Before I jump into kind of questions from the audience and a larger discussion, I do want to mention mechanisms. So for folks who have been in the field for a while, you'll kind of remember, I think, that mechanisms has not been something that has received a ton of attention. There was a meta-analysis done, or I guess it was a systematic review a few years ago that basically showed there was literally a handful, something in the neighborhood of 12 to 14 studies that had explicitly actually tested for mechanisms of action of implementation strategies. So with that knowledge and knowing that we need to start to understand why implementation strategies work, for whom, under what conditions, and potentially why that strategy works versus others, there is a major kind of renewed, I guess, not renewed, but just a new interest in implementation mechanisms. So there's a couple of grants that have been funded in recent years. Our inclusion of the mechanisms was really kind of an attempt to look ahead at where the field is going, more so than where the field actually is right now. And I'm not surprised in any way, shape, or form that people indicated that the mechanisms are going to be difficult. They always are the most difficult for all of us to do. We recommend leaving it to the very end, in part because, again, it's something that doesn't have a lot of research, so it's hard to just kind of fill in off of your own knowledge. But also, it's one of the things, too, that as you work with community, with the people actually implementing, there are ways to really kind of understand why would this have worked or why did it not work, and throw in hypotheses about that. There was a question in the chat about some of the mechanisms that we included, things like improving self-efficacy, things like that. And I think one of the questions was, isn't that also an outcome? It could be. It certainly could be an outcome. The thing is, it's not an implementation outcome, it is not a service outcome, and it's not a clinical outcome. Therefore, it becomes a process-oriented outcome that gets you to those ultimate outcomes. So that's why we would place that as a mechanism. In certain studies, if you're not actually getting to the implementation outcome, it may be the final outcome of your particular project, but that doesn't mean that it's not still a mechanism in a larger causal chain that would need to be specified in the logic model in its entirety. So that's kind of the reason that mechanisms is a little less fleshed out, is really a reflection of the field. We're just not quite at that place yet where we can definitively say, here's mechanisms that need to be tested, and here's what needs to be included there. We conceptually know what mechanisms are, and we can obviously go back and draw on our behavior change theories and other things to help us kind of think about what they might be. But that is a place where the field is not as good. So that's the main reason why I haven't talked as much about that.
Dr. Smith, a wholehearted thank you. What you provided us with is with really, it's not tools, it's a way of thinking, it's a way of supporting implementation science projects. And the implementation research logic model is, to some extent, it will also be part of the backbone of a project to make visible the richness of each of the different steps you take into an implementation science project. So I truly appreciate the content of your lecture, and specifically also the variability in the different ways that you can present this model, and also your invitation to further refine it, because this was also very clear. At the same time, you also pointed out to an area in implementation research which is still under major development, but which is growing in the recent years, which is this part of how and why things work through the mechanisms, going from implementation then into also the outcomes that are being observed. We have a number of questions, and I would like to ask, first of all, Amal Faka to ask a question. So Amal, please unmute yourself and make yourself visible on the screen. Say who you are, because it's always very nice to know who is speaking. And so please go ahead, Amal. You have to unmute. Or could people from AVL please unmute Amal Faka?
Yeah, hello.
We can hear you.
Hi, everyone. And hi, Dr. Smith and Dr. Sabina. Thank you for this very informative presentation. My question is actually on the use of the logic model, and as I understood, it could be probably a good way to plan for a prospective study, but my question is, can you use it to actually study already performed implementations of an intervention, like in a case study where you want to compare in different contexts, like different interventions related to one clinical benefit, for example, for the patient? So how can you use it? Yeah, how can you use it?
I think you certainly can. We have applied it to already completed projects, like pretty much entirely retrospectively, to think about what we did and how things actually kind of bore out in the project itself. I will say that it was very different from what was proposed. So it was a good exercise to go through that. In terms of your question about actually using it as sort of a case comparative study or a way to do case comparison, I actually had not thought of that, but that does make a lot of sense to be able to actually kind of pull together, multiple examples of kind of similar projects. This kind of goes a little bit to the synthesis idea of how to use it for synthesizing results, but you could also use it for just pure comparison. We are trying to use it in a project where we're looking at site-related differences. So they're all trying to implement the same thing, the same evidence-based program. They all received, for the most part, similar implementation strategies, but there are contextual differences, and there were existing strategies that differed by the different sites as well. So we're using it to try to understand the site variability, which does sound very similar to what your intended or what your potential use could be for it. In that particular case, what we've done is really just done site-specific IRLMs. And look for the things that are kind of, that really do differentiate that site from other sites. And some of that is very data-driven. We're actually pulling from our surveys, we're pulling from our qualitative analysis, but we're also just getting stakeholder input on things that existed or things that were present that we didn't measure. And that has been actually a really good exercise in and of itself, is to understand, like, we didn't know that they had, like, some of our health centers had quality improvement teams that were involved in this implementation. They didn't tell us that. So it was really good to actually go through that and kind of think very comprehensively about what happened, and then look for those differences that could help us explain why certain sites did better than others. So that would be a really cool use, the way that you're proposing.
Okay, just one last comment. So even if the outcomes were, for example, you could collect some implementation outcomes in one context, but you could not collect the same data in another,
Sure.
You can still compare, like.
You could, and you wouldn't be able to compare on the outcomes. You'd be comparing on your determinants and your strategies,
yeah.
And potentially any outcomes that are shared. That is one thing I didn't actually mention. In the majority of situations, you're going to have a logic model that you can complete, right? So you're going to be able to fill in what your intended ultimate outcomes are at the patient level, how you're going to get there by demonstrating the implementation outcomes, but it doesn't mean that all those are measured. So it could be that your study actually only focuses on the determinants and the strategies, and really, like, the outcomes and clinical outcomes and things are just, they're there, but they're not something that's actually being compared because you don't have that data. So you can just focus on, like, a couple of different boxes, and this would just, that would help you. Okay. Particular case, but yeah.
So I would like to move on to, thank you so much, Amal, to Tekla Brunker. Tekla, could you or Aviel can unmute Tekla Prunkert. And Tekla, could you introduce yourself and ask your question?
Sure. Hi, my name is Tekla Prunkert, and I'm currently doing a postdoc at the INS in Switzerland. And thanks a lot for your talk. It was very interesting to hear and to see specifically. And I can talk from our experience. So we used one kind of a logic model for our project. And one issue, I mean, I have more a comment than a question. One issue related to the mechanisms that we found helpful was also to put in some time dimension into it, because sometimes you need to achieve one thing to get to the next, and to somehow define this relationship in there as well.
Yep.
I felt was helpful. And also, yes, as you said, this can be outcomes, but this can also be things you can just describe that need to happen, but which cannot really be measured by a quantitative instrument, for example. So I think there is still a need for some further research to really define these mechanisms.
Yep, excellent point. I think especially if you're to test whether or not you've affected the mechanism, you're starting to think about, mediational modeling. And so you would need to have that time component. It can't be, measured retrospectively, or it can't occur before the strategy happens. Obviously, none of that stuff would make statistical sense. The thing I also really like that you pointed out is, there's the potential of actually going back in and retrospectively filling in the mechanism, even if it wasn't measured, for various reasons, that you could actually do that. You could look at the outcomes that you achieved. You could look at the strategies that were used, and potentially go back to implementers and ask them, about the actual mechanisms, like what changed. I typically do have like a number of slides about how to think about what kinds of mechanisms. About 75% of the time, the mechanism is going to be some sort of a derivative of the barrier that you're trying to address. So if the barrier is, this is a really straightforward example, maybe a little bit too simplistic, but you'll get the point. If the issue is that your existing staff is not well trained in this type of intervention, you would look at increased knowledge specific to the intervention potentially as one of the mechanisms to demonstrate how a training strategy actually worked, right? So you're actually taking kind of the barrier itself into the action-oriented term for the barrier, and making that a potential mechanism of action. That happens pretty frequently. It's usually something related to the barrier. But again, it's something that you have to measure at a later point in time for it to actually be tested or hypothesized as a mechanism.
So we move to Suzanne Daini. Suzanne, can you ask your question, or could you comment? Aviel, could you please unmute Suzanne?
Thank you. Yes, hi, my name is Suzanne. Thank you so much for this rich presentation. Actually, I have a question when you mentioned about the model that it might serve for like reporting, to use it as a protocol. You said we should differentiate between deviation and just doing some adaptation. So we know that if we have planned this at the beginning, once we roll out, we might go through some adaptations. Should we reflect this in the model, or should we use something different?
It depends. So I think if adaptation is one of your primary implementation strategies, so I don't know, that is always the case, is that adaptation is an implementation strategy. So if that's the case, one of your primary things that you think is going to need to happen for it to have an impact or for it to be implemented, I would recommend doing something more than just the logic model. There's the new Frame IS, which just came out in implementation science, which is a great way of doing it. I will say it's very, very in-depth, maybe more so than some of us would. And so you'd probably only want to apply that in a case where adaptation is the primary implementation strategy. If your protocol is more about, we know there's going to be adaptations, but we're not using like the dynamic adaptation framework to systematically make those changes, we just want to document them. The logic model could be used to document those modifications as they occur. But again, it kind of depends on if it really is a primary that you really want to understand, if there was fidelity to it, if that was the reason that things happened, versus it's like one of 15 strategies and it's really one of the minor ones, but you just want to kind of show and track what's happening. That's where I would make the distinction about whether or not you need to have a much more in-depth reporting framework or other way of kind of looking at it than just reporting some changes in the logic model.
Yeah, thank you.
I would now like to move to Andrea Brambilla. Please introduce yourself, say also where you're coming from. So Andrea Brambilla, can she be unmuted? And please switch on your camera. It's always lovely to see the faces of those who are asking questions. Is Andrea still online?
It seems like Mrs. Brambilla doesn't have a functioning microphone.
Okay, so I can say her question aloud, but it's, of course, I hope that it will be clear. I didn't understand if the logic approach to read this example is starting from the behavioral program, then outcomes, etc. Is that being presented, or the logic starting from its determinants and so following the rows? Dr. Smith.
Yeah, I hope I can answer that. Let me read it actually too. I didn't understand the logic model approach to read. Yeah, so I mean, we have kind of the suggestion that, we try to do the bookend approach for starting to populate the logic model. But every group that I've worked with has in some ways chosen to start at different places. So this really will be kind of project dependent. I know with a recent one that I did, we actually started with the request for application. So the RFA that we responded to was very, very prescriptive. And it said your primary outcome has to be this. You have to use these 2 implementation strategies, and you can use others, and you have to use this type of intervention. So we actually started with that. We filled in like, here's the absolute necessary parameters to be responsive to the RFA, and then we filled in everything else around it. So there really isn't like I kind of have said before, it's not really a step-by-step rule-governed approach. You could actually be an intervention developer who is starting to explore the very first effectiveness study or the very first hybrid study of your intervention. And so the intervention incredibly well. The outcomes that you've been able to achieve in efficacy research. So you can plug those in immediately. Then as you start to work with different community partners or potential adopting agencies, you could then fill in the determinants and then start to think about, well, what implementation strategies are needed based on your contextual factors for my program. So again, there's not really a wrong way to do it. It's really just kind of being able to plug in the things that are absolutely necessary and have a comprehensive and complete model that would be the ultimate goal. But the way that you get there, I've seen probably 19 different roads to Rome, so to speak.
So the next question is one which comes from myself, and in Europe, the Medical Research Council framework for developing, implementing, and evaluating complex interventions is in a lot of cases from implementation research studies also increasingly used. There has been a paper, Da Silva, which presented a theory of change approach, which is really a pragmatic framework to describe how the intervention affects change. And so it is, to some extent, I think, more elaborate than the implementation research logic model, as it really represents the causal pathways and specifies specifically the assumptions, how the mechanisms work, they're all in there. Yep. And is also not so rigid in view of the logic model in itself. And I just wanted to ask you, are you familiar with this Da Silva's theory of change? Because it's really suggested as a way to fuel the MRC framework and bottom line, make the engine more powerful.
Yeah, so I don't know if we actually cited Da Silva's theory of change paper in our paper. We did contrast kind of two other ways of doing similar things that the logic model says it does. One of which is just general theory of change and intervention mapping, which really is focused on the intervention and how it creates clinical change. And then the other side of that is Maria Fernandez and some other folks have essentially adapted intervention mapping to a thing called implementation mapping. That focuses on the mechanisms and theory of change of the implementation strategy. So it's basically two different levels, but trying to apply the same type of thinking. And I agree with Sabina that this does lead to much more detail. There's usually multiple steps in a causal path beyond just our one kind of mechanisms box. They tend to break it down in even more ways. But basically, we contrasted it with saying that, you know, each of those other frameworks only does one level. It doesn't do both levels simultaneously. We have had people, some projects that we've worked with who have actually applied one of those other frameworks to better study and understand the theory of change of the intervention or the theory of change of the implementation. So they're really great complements to the logic model. I think I personally view the logic model as being somewhat higher level and more integrated of all components, where these really go deep dive into those specific things that they were designed for. And
the Silver combines both of them. The Silver really combines both of them, so it's both implementation strategies as well as the intervention components, and it's very dynamic. It's really going into understanding how a specific intervention implementation strategy also combined will then result in outcomes. But there's a lot of options around, and I think it's important to get familiar with several ones. And in the end, it's what helps you in your thinking and in your work. I mean, there is not just one way to Rome, as you said. I liked very much that expression. Dorothea Hellberg, would you like to ask your question? Dorothea Hellberg, if she can be unmuted. And if she's
it looks like I'm going to have to pull up an example, so I'll do that too.
So I don't know if she's still online. Juliane Barney, could you please check if the people are still online, because otherwise I will go to somebody. I go to Sabina Valenta.
I think she did say later question answered, so maybe we don't need to do this one.
Sabina Valenta, could you perhaps ask your question? Thank you.
Yes, hello, hi. My name is Sabina Valenta. I'm a postdoc, doctoral research fellow, and I'm also an advanced practice nurse in the University Hospital in Basel. And my question was also related to the mechanism box you have presented. And here there was an example, self-efficacy improved, for example. And then I've thought, is it not already an outcome? For example, self-efficacy improved, and how can I differentiate between the statement in the box mechanism and as an outcome?
But I might have already addressed it, but I'll say it again. That, you know, it would be an outcome if that's the end stage of your test. So if you were, I mean, I could see this definitely happening in like a pilot study, where you were trying to say whether or not a couple of implementation strategies, probably around training and supervision, actually led to increased self-efficacy. The thing that it doesn't get at, and this is why it would be probably an incomplete or just not the best outcome for a large study, is that self-efficacy is not in and of itself behavior change. So you'd still want to demonstrate that self-efficacy led to adoption, led to an improved fidelity of delivery of the intervention, something along those lines that actually gets further down the causal path. But if you were trying to say, like, you know, we just want to show the initial effectiveness of a potential strategy, you could treat it as an outcome. And that's true of any of them. I mean, if you wanted to, you know, sometimes the implementation gap is that you just need people to adopt. And then you're not necessarily looking at, you know, fidelity and reach and sustainability. So you could stop at kind of any of the different stages in the causal chain, depending on kind of the context and the obviously rationale for your study.
Thank you.
And I would like to give Martina Roos the word for her comments and question. Martina, can you also introduce yourself?
Sure. Martina Rose. I work for a research center on dementia research in Germany. I have a question actually that is also related to the mechanism, and I was wondering if the realist evaluation approach might be helpful. And the other is more about how do you think that your logic model will improve the whole outcome, implementation outcome discourse itself? Because we already know that all the models you were referring to, either the REAIM or the Proctor or the others that were in your presentations, they provide difficulties operationalizing. And I think that is what we have to look at it from, maybe from a methodology perspective, you know, because I mean, if I really want to use it, then the question is, what does it mean with regard to my implementation? And I guess quite a few questions were there. So I wonder if, you know, on a methodology perspective, you think your model can contribute to that one. And the third part is, I mean, of course, we're all familiar with Laura Damschroeder's model. And I saw what you put in the intervention, you know, when you were talking about the intervention. And I always understood that Laura was saying, we have key elements and we have peripheral elements, and that includes already the adaptation. So of course, in my understanding, that means that the adaptation of the intervention is always part of the implementation strategy, but it is a key element to define outcomes, you know, either on the intervention perspective and also on the implementation perspective. So they all somehow linked. So hopefully you will be able to provide some kind of insight. Thanks.
Yeah, so I do think that realist evaluation could be helpful for the mechanisms. I haven't personally used that, but it makes sense that that would be something that could be used to try to do that. In terms of like the kind of operationalization of outcomes, you know, I think one of the challenges that we've had working with folks in general, you know, with or without the logic model, is, like you said, actually operationalizing this for my particular project. You know, there's a lot of kind of contingencies around which level of the implementation outcome you're looking at. You know, for things like reach, you know, what kind of a reasonable denominator can you actually find? Like all those things are major challenges. I think the one thing that the logic model would help for is to get people that actually have things that are better aligned with their actual project. So I also review a lot of projects. I also published a paper that was a mapping review of published NIH funded HIV implementation science projects. And there was a tremendous amount of mismatch between what people said were their implementation outcomes and what their strategy was. So they were a strategy that was at the individual provider level, but they were measuring an outcome at the clinic level or vice versa. So there was just a lot of mismatch between, you know, kind of core elements. So I think what it can help people do is actually try to a little bit better. I don't know if it's going to help people actually operationalize or understand REAIM any better, but I'm hoping that it leads people to have just a better alignment between the totality of the project. And then your last question, I'm already forgetting it. Oh, unmute.
It's about the adaptation, you know, I mean, one key element of the intervention is that we have key elements, but also peripheral elements, and the adaptation of the peripheral elements will also link to that this is where adjustment happens, you know, based on which organization you're going to. But it is also a request for the interventionist to really define what are the key elements of the intervention. So you already have some kind of ideas, or you're using the implementation strategy to do the adaptation. So I think we need to discuss the outcomes based on adaptation, but also you use it as an implementation strategy. And I always get the feeling that it's not really used as an implementation strategy like you were proposing, that adaptation is a key element of implementation.
Yeah, and I think that's kind of one of those things that, you know, David Chambers talked about this a lot in his paper on the dynamic sustainability framework, is that he basically said adaptation is going to happen. Like, it doesn't matter if it's planned, it doesn't matter if it's a strategy, it's going to happen. And in most cases, it's a good thing. Like, it's a way to actually achieve better fit between the context and the intervention itself. That is making the assumption that you rightly pointed out, that those adaptations typically on the adaptable periphery, as Damschroeder calls it, rather than adapting the core key elements. So the one thing that I think is always important is if you propose prospective adaptations, that one of your outcomes better be fidelity. It better be fidelity to the core elements of the intervention to be able to say that you didn't affect the things that are most likely to be leading to the change that's experienced by patients. But that is a really difficult thing. And I think people, more or less emphasize the adaptation component of an implementation study. Some just treat it as a nuisance. Some treat it as this is the main thing that we're going to study. And then there's everything in between. So I think it really does depend on kind of what you're focused on and maybe how big of a derivation are you trying to make from where the intervention was originally implemented to where you're going now, because that would dictate whether or not it needs to focus or whether or not it's something that could just be tracked over time and maybe reported at the end. Good questions.
I think we come to the end of our webinar of the Swiss implementation.
I only have one last comment. Based on that, I think the process evaluation could help to get a better understanding of what is going on. So I think that's probably something you had in your model as well, but you didn't mention it specifically. But I think this is exactly where process evaluation can be helpful.
Yep, agreed.
Good. So we come to the end of our webinar of the Swiss Implementation Science Network. I would like to wholeheartedly thank Dr. Smith for joining us today, really inspiring us in view of the implementation research logic model. May I ask AVL to show the slide set again?
Or I can.
No, it's just our slide set with the with our announcement of the next webinar. Absolutely. And so we do look forward to see you again on the 23rd of June. And there we will, at the same time as today, please the next slide. We will have an implementation science study, a public health intervention, which was done in whole British Columbia in Canada, in which a physical activity program for older adults was being adapted and implemented and evaluated, and hybrid 2 design. And Heather McKay and Dr. Naylor will present their program of research, which is a wonderful example how different elements of implementation science can be used for very successfully achieving something most difficult, which is getting older persons moving more. Dr. Smith, I think you are available if there would be further questions by your contact details, and they will be on the website of Impact. And so I would like to wish all of you a very nice evening. If you're in other parts of the world, and good rest of the day, or perhaps even, a good night. And look forward really to reconnect in June. Thank you, Dr. Smith.
Thank you.